Okay, so the first bit of the talk that I'm going to give is really about doctors' well-being in the BC era, the before COVID. I put 10, but of course it's 19. I apologise for that. Because I think it's really important, if one's talking about doctors' well-being, to think about the starting place. It may seem as if it was in a previous BC era, but actually, of course, it's only a few months that our lives have been turned upside down. And so I just want to begin by thinking about the whole issue of well-being before COVID hit globally, and then I'll take some questions, and then Naomi is going to think about the current era. So next slide, please, Naomi. So this is just it's a bit out of date, but December 2016, 3.5 years ago, and I imagine you guys are all very familiar with these sorts of statistics. This was a survey of junior doctors. 80% felt that their work sometimes or often caused them excessive stress. Nearly 20% had to carry out clinical tasks for which they had not been adequately trained. Now, of course, that may become an even more important issue in the era of COVID. Quarter felt that their work had a serious impact on their mental health. And crucially, and this is a common finding, nearly half felt that their lack of well-being had a serious impact on patient safety. So this was really the sort of starting point. Next slide, please. And this was a King's Fund quarterly monitoring report, and there have been more recent ones, very similar, probably a little bit more acute, and they show how really the concerns about doctors, junior doctors and consultants and GPs' well-being in large part is because of the demands and the performance targets that are being put. Because if we have the next slide, what we've seen, and this is a global, crucially, this is really, really important, that the issues of medical well-being, the issues of burnout are a global issue. If you amuse yourself after this talk by going into PubMed and putting burnout and doctor in an abstract search, you will find thousands and thousands of papers from really all over the world, literally all over the world. So this is not a UK problem. It's not only an English-speaking problem. It's across the world. And there are reasons for it. And if you want to peel back the reasons, we have an aging population, rapid increase, advances in medical knowledge, and exponential growth in treatment. So there's a huge increase in the volume and the complexity of patients. And then there's also, whether you're in a taxation funded system as we are in the UK or an insurance based system, whatever the system, there's concern about the cost, and there's an increased regulatory burden and clerical burden. And I think this is the point, because I'm a psychologist, what I want to think about is how these have undermined the human interactions at the heart of healing. And those human relationships are between the doctor and the patient. You guys are pediatricians, so it's going to be between the doctor and the parents of the patient, but also between the doctor and their own medical and wider healthcare colleagues. Next slide, please. I feel like I'm giving the government briefing by saying next slide, please. And I have failed to understand why day in, day out for the last 10 months, Chris Whitty can't press his own button, but maybe for the same reasons that but you would think the government might be able to sort that out. So this is a guy, Tate Shanafelt, whose work I much admire. He was at Mayo Clinic in Minnesota. He's now at Stanford Health. He's the first ever, he's an oncologist with a very impressive research record in oncology, but he's also done a huge amount on burnout. And what he says, and it's the details of the paper in the previous slide, and you'll see that the slides will be sent to you, about how collectively the increase in demands, increased regulatory burden have created a protracted interval, a protracted period of doing more with less, while simultaneously eroding meaning and purpose in the work of health professionals. If we could have a poll, I'm not going to ask you to unmute, but perhaps in the questions, it'd be interesting to think about how many of you agree with this, that it accords with your own experience, that prior to COVID, you felt you were doing more with less, and also that the purpose and meaning had become eroded. So why does this matter? Next slide, please. Why does it matter? Well, I think that we need to, and the next slide again, please. I think we need what I argue, and I argue in the book, and I argue more actually I sort of came to the cusp of this understanding in the book, but after the book was published about 2 years, just over 2 years ago, did a huge amount of talks and lectures and workshops all over the place, and my thinking has slightly moved. It's not that I don't agree with my conclusion in the book, but it's also moved on slightly, and I have become more and more interested in the relationship. So Enid Barlint, wife of Michael Barlint of Barlint Groups, that some of you may have experienced, more common in GP education, wrote, and I think this was about 1979, long time ago, 41 years ago, at the center of medicine, there's always a human relationship between a patient and a doctor. This is the unchanging core of medical work, despite whatever technical advances are made. And I think the core has changed. I think this is what is lying at the root of the burnout, is that the relationship, and actually it's not only the relationships between the patient and the doctor, or in your case the patient, the parents, patients and the doctor, but I think we've seen an erosion of relationships. And so if we move on, next slide please. This was Kieran Sweeney. It was a GP and a professor of general practice at Peninsula Medical School, and he tragically got mesothelioma, which he attributed, and died about 18 months after diagnosis. He attributed it to the removal of asbestos in the basement where they had the anatomy labs in Glasgow Medical School. And he wrote, if you haven't read that paper, I would encourage all of you to read it. It's a blistering, extraordinary paper. And he reflected on his treatment, and he reflected on the fact that it was technically impeccable, but the relational aspects of care lacked strong leadership. He was discharged without being given his diagnosis. And he describes in this paper how he learned of his diagnosis on a summer lunchtime with a glass of chilled white wine with his wife behind him. He picks up the discharge summary, and he reads that he's been diagnosed with mesothelioma, which he knew the implications of, but nobody had dared to talk to him during the time he was an inpatient. And it's these sorts of and he just highlighted the relational aspects of care. Next slide, please. I think that we can learn about the relational aspects of care. I love this photo, it's a beautiful photo. And I think this should be particularly resonating with this cohort that I'm talking to this afternoon, because you're pediatricians. And I think we can we can draw some parallels. I want to emphasize, I am not saying that care of the pediatrician's care through the patients is the same as a mother's care for their child. I do not think they're identical. I think in all sorts of key ways they're not identical. But I think that if we unpick maternal care, it can highlight some aspects that get overlooked when we think about how that might apply to medical care. So next slide, please.
Oh, whoops.
Oops. Donald Winnicott, who, oh no, we missed one, but no worries. Donald Winnicott, who many of you may have heard of, who was a child psychoanalyst, but also a pediatrician, and had a great understanding of children and things like the transitional object or the good enough mother, some phrases which are really in common parlance come from Winnicott initially. In a key paper said there's no such thing as a baby. A baby cannot exist alone, but is essentially part of a relationship. And you know that as pediatricians, you know that if you want to improve the baby's, the health and the mental and physical health of the baby, who do you support? particularly of the infant, you support the person who's giving that care. But I think that relational aspect has been entirely lost when we think about doctors looking after their patients. Another great thing of Winnicott, next slide, is that Winnicott knew that this was not motherhood. Motherhood is not all motherhood and apple pie. And next slide, please. He was very, very clear that parents, and I looked very hard to find a picture of a child that one does not warm to, of a toddler who one does not warm to, in a wonderfully sort of slightly tongue-in-cheek, but also has a serious element. He, the baby, is ruthless, treats her as scum, an unpaid servant, a slave. He's suspicious, refuses her good food and makes her doubt herself, but eats well with his aunt. There are 14 left. I just picked up the 2 of them. But the idea that parents may at times have very aggressive feelings to their children, and that's normal. He's not advocating that they should act out those in any shape or form, but he's advocating that they should recognize precisely so that they don't act them out. And I think that there's nothing parallel in medical training saying that you will have difficult feelings to the patients that you teach and their parents. And you want to be aware of those and be able to think about them so you don't actually act them out. And I think, although Winnicott didn't make this, I think that there's a further parallel that one can make. And in a way, life is very curious. And I can't think how many years ago, but I think it might have been 25, but it may have been 30 years ago when I did my PhD. It was actually on psychological aspects of pregnancy and maternal depression. But I moved on to do very, very different work after I finished my PhD. But critically, Trump won't like this slide with the World Health Organization logo. Critically, maternal depression is common, and although in maternal psychosis that there can be some genetic elements, and yes, prior psychological difficulties increase the risk, but crucially it's the mother's network of support that is really critically important. And for me, next slide please. This was a comment that a FY2 trainee said to me last year, and I just asked her if she could use it. She said it in a career counselling session, and I can write very, very fast. I'm run ragged. I can't look after the patients in the way that I want. I've been shouted at by my seniors. I'm all by myself in this giant hospital covering the post-surgical ward while my seniors are in theatre. I feel so alone. And I think that just covers so many, the exhaustion. They can't look after the standards you're setting yourself, how you want to be a competent professional. You can't meet it. I've been shouted at. I'm alone, not for you don't belong everywhere, the isolation. And I imagine if we did I don't think we've got a poll function in GoToMeeting, but I imagine if we did a poll that there would be a very high percentage of you as senior paediatric trainees who, if you look back over your training, actually can remember that the moments when you felt like that. And next slide, please. I don't want to be accused of, somebody who just looks back on everything with rose-tinted spectacles. Next slide. But I think that we need to look at all the ways, and this is just some things that I've observed and people have told me about, but I'd be interested to hear your views on top of this, about all the ways in which supportive relationships have been eroded over the last 10 or 20 years. We have larger medical school intakes. So if I ask doctors who are coming to the end of their training and their end of their careers, who are like me in their 60s, their medical schools would have been 120. Now some of them are 500, 600 even, I think, at Manchester. You can fall beneath the radar. You can get lost in these. Foundation doctors used to go and work in the hospitals on the whole linked to their university where they'd done their undergraduate. And with smaller medical schools, they would have been there working with people they know. Now they know move all over the country. And I've had consultants say to me in horror that they've had 2 trainees from the same medical school who've never met, who don't know each other. Rotations lasting 4 rather than 6 months. Yes, I understand the reasons for the modernising medical career reforms, but it's like musical chairs, and that becomes harder to build up a sense of competence. It becomes harder to build up some relationships. Doctors living off site, the removal of the doctor's mess. Some brave trusts are bringing that back and replacing the old style firm with a shift system. So these are some of the things that belong to perhaps earlier on in training, but I think the relationships, and this is what I'm keen to be emphasising, have shifted. The next slide, please. Many of you will be familiar with the case of Dr. Bawagaba, and I think a paediatrician, and I think that that was a watershed moment because it made everybody feel vulnerable. Because if you looked at the reports that the hospital carried out, these were system failures. There was problems with the IT system. Her consultant had double booked himself and chose to go and deliver teaching rather than to being on site. There were all sorts of layers. She was recently back from mat leave, very poor in re-induction on her return, all sorts of reasons. But I think, and one could think at least some of those in relational terms as well. And one has to name it. One has to name as well the issues around racism in society as a whole and in the medical profession, and the issues that we're seeing currently in terms of the differential morbidity and mortality that need to be unpicked. So next slide, please. This is not where we want to go. So I've taken out who wrote this paper and where it was said. A good healthcare professional is one who's compassionate to themselves and their own well-being, enabling them to care and treat their patients. That is not where the emphasis should be. Yes, you need self-compassion. Yes, you need well-being. That is important, but that is not the main reason for these for the study after study showing burnout and lack of well-being. Next 2 slides, please, just in quick. So I think the emphasis on you, the responsibility, it being your responsibility to look after yourself. Next slide, please, Naomi. That is closed. That is not the way to go. And it's not what needs to be done. We need an alternative route. And so I'm going to explain what I think, and I think it is happening actually very slowly. I think a better model for how we needed to think about it before COVID, and even more we need to think about it now during the era of COVID, is that we need to be thinking systemically, and that the parallel is therefore, next slide please. In fact, no, we're going the wrong way. The parallel, thank you. The parallel is, and I talked about this in the conclusion of my book, is about what can we learn from infection control? And if we think about parity between this was just me being wordplay really, but parity between affective and emotional well-being and the infective. Next slide, please. Because 150 years ago, this guy, it's a bit over 150 now, but 152 years ago, this guy, Joseph Lister, was laughed at when he suggested that it would be a good idea if you're amputating limbs to wash your hands in soap with carbolic acid between amputations of limbs of different patients. And he was told it was nonsense. It would take too much time and it didn't really make a difference. And I think what we're doing now in terms of emotional well-being, next slide please, is that what we're doing now we know in the current climate that washing our hands is really important, but in terms of both medical practice and the wider population, we are not limiting the response to COVID-19 in terms of washing your hands. For the population, there's social distancing. And and wearing masks. In many countries that has been mandated, not in the UK. But those are the population strategies, to say nothing of isolation if you're in contact with somebody or if you think you may be developing the systems. For the healthcare providers, then of course there's been a huge just layer and layer of infection control procedures. So washing your hands is important, but it ain't the whole story. And the whole story requires infection control before COVID, and even more so now, requires a systemic approach for people, for institutions, for populations, for the nation as a whole. And that is the systemic model for what we need. So nearly at the end of my talk. Next slide, please. Professor Michael West, like me, an occupational psychologist, he was commissioned to do a health and well-being review by the GMC that was published last year, and he comes at it a different way, but he said the same things that I was saying in the book, that yes, individual stuff like mindfulness, like protecting your sleep, like looking after your diet, like exercise, these are all really, really important. But ultimately, it is the institutions that are responsible for this. And he highlighted 3 things. He gave them slightly different terms, but I like the sort of ease of memory. So control of your work. Your well-being is, if you don't know your rota until the last minute, if you are being moved around the country all the time, all sorts of ways in which you don't feel in control of your work. And of course, that may be even more important when Naomi comes to talk about post-COVID. You need to feel that you belong to a community, that you belong at work. And I think that has a sort of parallel of the social support that is needed postnatally. You need to feel that you're fit for purpose, you belong, and there are people who you can go to if you're unsure of, because that's what helps you with the 3rd point, which is competence. Nobody, there's not a single person who's listening today, of the 49 people who are here logged on to this talk, none of you went into medicine, none of you went to med school, none of you have ploughed your way through long training programs to deal a rubbish job for your patients. That's not why you went into medicine. You are motivated by doing a good job for your patients. And if you feel that you can't do a good enough job, and that is some of the feelings that Tate Shanafelt has picked up in his research, you are going to be distressed if you feel you can't do. And that comes on to the sort of work on moral injury that has been discussed quite widely in the sense of COVID. So I think, final slide, please. In a way, this is, if you take nothing else away from my talk, it is moving away from individual focus on this whole issue of relationship of well-being, to be thinking about systemic responsibilities, the responsibilities of teams, of organizations, and of course nationally. And how do those responsibilities, why are they so important? They pans down because it all ultimately drills down to the quality of the relationships that medical students, junior doctors and senior doctors experience in their day-to-day work. So that is me, and I'm happy to take a few questions if Tesha, you want to.
Hi, so just looking at the chat box, we've definitely got an agreement that things do need to change. I was just thinking myself, these are super important points that we need to take on board. There are no current questions, so I was hoping to just pop in with a couple of my own very quickly.
Sure.
So mentioning, it's interesting that you mentioned that the well-being of trainees are focusing on our own mental well-being and mindfulness, all of these things that we are being told to do. You feel actually that's not the main solution, and it's all about systemic improvement. I just wondered if you had any examples in your experience of trusts or hospitals or teams that have implemented change and managed to improve the way they support trainees.
Okay, so I can do one example, and actually I talked about it briefly in the book. I would say that Mike Farker's work, and some of you may have worked with him at the Evelina, his work on sleep, and that sleep is only one issue, it's a really, really important issue, but changing the culture culture where, instead of a culture where people are told, and I don't know how you know, I'm not going to say that every team within the Evelina that happens, but I'm sure there are at least some teams within the Evelina, when you're working a night shift, the culture is you should go on a break now, and if possible go and have a 20-minute kip. And that is against the culture which says, when you're not paid at night, you're not paid at night to have a rest. So that would be, and I also think, and I actually wrote about that briefly in the book, I think another reason why Mike Barker's work is so important is that it's an example where doctors' knowledge, clinical knowledge, he's a pediatric sleep medicine specialist, their clinical knowledge, he knows about sleep, yes, in children, but he knows about sleep in adults too, and the impact that sleep deprivation has on errors and the quality of performance. He's applying that to doctors. And the reason I wanted my book to be called Also Human, and I'm really pleased that it's sort of a hashtag now, is that there needs to be an acceptance that doctors are also human. And so stuff that applies, depending of course upon your discipline, but some clinical stuff that you know from your professional roles, why not apply it to yourself? So that would be one example. A GP example, that's a post-COVID, is talking to a very senior GP at the deanery, and talking about how they've instigated virtual huddles every day in their practice, which they were always, quote, too busy to do. But they've done that in COVID because they had to, and how beneficial they've found it. So those would be two quick examples.
Great, thank you. I've just seen another question. I think, Susie, hopefully I've already asked your questions about what can institutions do to improve our well-being. Chantal has a question, which I think is really important. How can we recreate the benefits of the firm in specialties with heavy shift work and in situations where you never work with the same people twice? Do you have any thoughts on that?
I mean, I think it's really difficult. I mean, it might be possible for everybody to be brought together very early on at some point, even if it's for a social gathering.
Okay.
And even if it's done virtually, it should be possible now. And I think that some of the potential, you know, I would much rather be giving this lecture and seeing 49 people in front of me. There'd be more energy, and my grandson might not wander in, all sorts of practical things. But there are some pluses potentially, and I think that would be one. Yeah, you cannot have a team if people are and although I am in general against the comparator for the psychological pressures of medical work to be the airline industry, one can, for all reasons which are beyond today's talk. There are some things one can learn, like a team in BA, you know, that they are constantly working with staff that they never work with again. And they have found ways of so that would be a kind of an initial thing on spending 5 or 7 minutes right at the beginning. That's not a waste of time. So I think that to think about ways in which relationships can be built.
Okay, thank you very much. I think, shall we move on to Naomi, your talk now?
Sure, yeah.
Thank you very much.
Okay, so here's the bit where I just struggle to just, oh, here we go. Yeah, tech, hey, what's happening? I'm guessing no one can see the screen yet. People can see, oh, they can see. Okay, you can see the screen, yeah. Okay, we just need to open up the, okay, there's always a little lag, I've noticed.
Right.
But yeah, okay. So you'll see I've entitled mine after Caroline's concept, that novel concept that we doctors are human. But first, a waiver. I would like to stress that I'm not a COVID expert. I'm sitting on the sidelines, not practicing, not seeing any patients. So therefore, in relative safety, completely in awe of you guys. So my privileged position just allows me to take a few moments to gather together some valuable information, hopefully from various different experts, and I hope you'll find this helpful. So what I will cover is essentially, and maybe largely because my background is as a psychiatrist, I'm kind of interested in how likely is it that doctors will need psychological help, and kind of what can we do. So apologies for the busy slide. You don't have to read all of it. So I was at a webinar, a Royal College of Psychiatrists webinar, and one of the speakers said that up to 30% of doctors will need some level of specialist help by the time we're done with this pandemic. And I thought, oh, wow, that's a bit high. But then I noticed that one of my ex-colleagues from Cambridgeshire, a psychologist, had done what she calls a rapid meta-analysis. She's hoping it will be published soon. I don't think she's got a taker yet, but you'll see that she has looked at 19 studies of comparable pandemics in other countries, and the prevalence rates of psychological symptoms amongst the healthcare workers are very high. So for PTSD symptoms, they are way higher than you would get in rescue workers. But what's interesting, or perhaps not so interesting, is that the rate does come down in time, which is completely consistent with the literature on post-traumatic stress disorder. And there are higher rates. We often get very excited about PTSD, but you have to remember things like anxiety and depression, and the rates are really very high. Interestingly, going down a bit in the sort of middle phase, but then in the later phase coming right back up again. So the BPS, the British Psychological Society, have published some really helpful guidelines. Actually, there are really helpful guidelines for the public, for all sorts of people. And there's a webinar that you can have a look at. I've put the website at the references at the end. So they're talking about, and you might recognize some of these phases. It'd be interesting in the discussion to find out whether you do. So they talk about a preparation phase with quite a lot of anticipatory anxiety. I would imagine there'd be quite a lot of sense of excitement in that phase as well, in a kind of weird kind of way. They talk about an active phase with camaraderie, challenge, disagreements maybe, and some loss of routines and norms. They talk about a disillusionment phase or an exhaustion phase. Again, it would be really interesting to find out whether anybody has observed any of this kind of stuff, where practitioners are finding themselves a little bit on autopilot, and just trying to free up my screen so I can see it. Greater sense of disconnection, perhaps some level of stress at home, and they say that this is the phase of the highest psychological risk, particularly for those with pre-existing vulnerabilities. And they talk about a recovery phase in the sort of longer term where psychological impacts can show themselves. So I was given permission to, can you see the next slide? To show this slide. This is from Sonia Wallbank, who has the title of Head of NHS Culture Transformation. I had no idea that such a role existed. And I suspect that this is more of a kind of theoretical rather than empirically driven slide. But she sort of, you can see that she's talking about sort of waves, peaks and troughs, and she's talking about sort of active phases of activity and so on. And then she's talking about sort of shock waves and the kinds of things that people find themselves thinking. I'm still working just as hard, but now we're more out to the public eye and kind of having to readjust to what work is. But I was thinking that in a way these waves would probably map onto the waves, the different waves of the, unfortunately, we probably will have second waves of our pandemic in this country. Even the really good countries that have managed their pandemic extremely well sometimes have second waves. So I was kind of playing with just kind of transposing this pattern on and on. But then I was thinking that in a way that there would be this sort of pattern for each individual, wouldn't there, really? So it gets very, very complicated. To simplify things, to return to the slightly more simple measure, the BPS have kind of given us a kind of adapted version of Maslow's hierarchy. So I'm sure some people will be very familiar with Maslow's hierarchy, where you're going to attend to your very basic needs. Like Caroline said, that might be things like sleep, but most importantly, of course, safety. And then at a slightly, just one notch up, the need to everybody to have support. And of course, that support is completely dependent on how systems are organized and how the leaders enable that to happen. And at the very top level, psychological intervention for those who need it. And I think running through all these levels, of course, there needs to be equality of access for everybody and fairness. So I've mentioned leadership, and of course that raises the question, what makes a good leader? So these, of course, are very familiar faces by now. Some commentators have said that women world leaders, some of them have done particularly good jobs, and that some world leaders have done, rather less good jobs. So what makes a good leader? So we can look to studies, occupational psychology studies. I mentioned fire and rescue services earlier in this talk. So there's a nice study that's come out of a Brazilian fire and rescue service, and they collected data shortly after a dam burst incident, collecting cross-sectional data, even though it was a longitudinal study, from fairly new recruits. And the collected information about psychosocial working conditions, so that is something they call job demand. So it's many questionnaires asking about all sorts of different aspects of the person's job and, in effect, how demanding their job is. Job control, in other words, how much control that individual may have over how their job is done, and the level of social support they perceive. And these three aspects of psychosocial working condition were examined in relation to psychiatric symptoms. So you'll see that the percentage of those reporting mental health difficulties at a level to need psychological support is a lot lower than you get in healthcare professionals in pandemics. And unsurprisingly, the greater the exposure to the trauma, the greater the level of mental health symptom. Again, unsurprisingly, the higher the level of job demand, the poorer the mental health. But a little bit reassuringly, the higher the level of job control and the higher the level of social support, the better the person's mental health. And this next slide just depicts these interactions in the sense that you can see that the first slide with psychiatric morbidity up the y-axis and low and high job demand on the x, but that if you have a higher level of social support, this will be protective. And on the second figure, again with low and high job demand on the x-axis, if you have a higher level of job control over your job, it will be protective. So this kind of raises the question, well, what is it about leaders that can enable these things? So I was searching for a study of medical leadership and didn't come across too many of those, weirdly. It's much more common in the literature to find studies about leadership in other parts of the healthcare system. So this paper by Cummings et al. Looked at leadership styles in nursing, and they included 53 studies that, in order to qualify for the study, for the review, the study had to have multiple outcome measures, but they classified the leadership style that the respondents were asked about, that they were experiencing. All of these styles boil down to two main styles. You've got the sort of relational, people-focused leadership style, and you've got a task-focused leadership style. I straight away homed in on one of those as one that I was very familiar with from my time as clinical director, management by exception. I could talk to you about that and the downsides of that till the cows come home, but I won't. But what Cummings et al. Found is that it was on almost all of the outcome measures, and you'll see that there are some hard outcome measures and some soft ones, but across almost all of them, a relational leadership style was associated with better outcome measures, and task-focused leadership is generally associated with poorer outcome measures. Of course, there were some exceptions. And this takes us back to Professor Michael West of the King's Fund, who Caroline mentioned earlier. And I've put the link to this website in the last slide as well, because I felt sure that you were going to say, well, what counts as compassionate leadership? How do we do that? How do we recognize that when it's shown to us? So this quote is perhaps a little bit helpful. Michael West talks about compassionate leadership involving leaders encouraging team members to listen to each other with fascination. I was struggling to remember a time when people listened with actual fascination. To understand each other's challenges, empathize and support each other. Such teams, research shows, are more innovative than teams that don't practice these team working skills. Those supportive teams with compassionate leadership have lower error rates, less stress, lower injuries, less bullying and harassment, and in the acute sector, importantly, lower levels of patient mortality and higher levels of innovation. So that certainly gives pause for thought. But obviously, even in an ideal world with the most compassionate leadership, we have to acknowledge that people's exposure to trauma is very, very great indeed. And many of us have individual vulnerabilities. So I've just included a range of resources on this last slide to help individuals who might be struggling and leaders. And the last two on this list, the BPS and the King's Fund, are the ones I mentioned earlier. And that's all from me. Thank you.
Thank you.
Thank you so much, and thank you particularly for these resources at the end as well. I just, before we move forward, I've got a question from Chantal, which I think is really interesting. Do you think that the attitudes of the public treating healthcare workers as heroes will increase the psychological stress at the end, particularly in a specialty like paediatrics, where lots of our departments have been less busy than in the average during an average winter? And how can we help colleagues deal with this?
Shall I go first, Caroline, on that one?
Yeah,
So I think, I think in the moment, I'm sure it must be very uplifting and you just ennobling in a way. But of course, you know, it's I suppose it's a bit like Christmas, isn't it? It has to end, and well, I believe it has ended now, hasn't it? Last Thursday. But yes, I think the hero story has definitely got two sides to that coin. There's a bit like the slide with all of the ups and downs, and I think that because it will raise people's expectations, and I mean, I suppose many people will think to themselves, well, they will think of heroic moments and get a very well-deserved glow when they think of those things. But there'll be other times when, you know, things weren't going so well, and they will the hero narrative could be a very, very bittersweet. You know, I mean, how none of us can live up to these sort of images, really. So I think that it could that story can have a very detrimental effect as well, perhaps in the longer term. What do you think, Caroline?
No, I agree. I mean, in a way, it's a bit like Winnicott's Good Enough Mother. I think you have to learn to be good enough doctors. And as you're indicating, if hero means perfection, I think that's a, you know, that becomes something that people can just beat themselves up when they feel that they and lead to a lack of self-compassion. So I think it's dangerous. I also think I was very interested both in terms of doctors getting in contact with me for the one-to-one work I do through CPD, Career Planning for Doctors, but also it was entirely paralleled because I do some freelance work for the Professional Support Unit. In March and April, nobody was getting in contact, and I think that is linked to the hero, because if you're having that military analogy, then if you want out, or you feel, you know, you can't bear it anymore, what are you? You're a deserter by extension, and nobody wants to be, you know, to see themselves in that way. And then in May, in the deanery, in the Professional Support Unit, it's been the busiest ever. So I think it is, but I think that in a way we want to hold on to a bit of the hero narrative. People need feedback. They need to be told that they're doing a great job. And if you think back to your day-to-day stuff, when somebody just takes a minute to say you did a great job there, that was really tricky, or, you know, you've really come on a lot since the last time I saw you do that. Whatever it is, we need that. We need feedback. We need that support, but we need it within a realistic, not within an idealized framework. And I think that is going to come back to skilled leadership.
So would you recommend that, as much as we appreciate the recognition from the public for the work that we're putting in, we need to be cautious and focus inward as an organization to build those interpersonal relationships you're talking about? And
yeah, absolutely. And you know, if one wants to return to the military analogy, good military outcomes was never just about one or brave soldiers on the front line. There was all the strategic stuff that went before it, that meant that the soldiers on the front line had been adequately trained and had the equipment, and they were actually in the right place, and blah blah blah. So yeah, it gets back to the systemic stuff.
Absolutely. I just have another question as well, please. And this is for both of you, what contribution do you think we can make individually as doctors within our own spheres of influence, and I guess developing our own relational leadership skills in terms of improving our interpersonal relationships with our own teams, no matter how large or small they may be. Do you feel there's a contribution to be made? And if so, how do you suggest we go about that?
You want to say something, Naomi?
Well, I mean, I was thinking several things. I mean, in a way, well, firstly, peer support is enormously important, isn't it? And providing peer support is a form of leadership. I mean, so I would imagine that in every episode, in every interaction or piece of care, there are small leadership roles. I mean, if you think about it, you know, in anything that you do, there's probably going to be someone taking the lead and someone following. And I suppose the other thing is followership is really important too, allowing other people to be leaders. I think developing excellent listening skills is hugely important, and that can be done at every level, even the most junior level, and I think, just coming back to the question about what makes a good leader, the compassionate leadership, most of it is about listening and working out things together with other people and not impulsively.
No, I think that's right. I'm just also thinking about, there's an article in the New Yorker that I read, written by Atal Gawande, who wrote Being Mortal, about COVID-19, and I would encourage you to see if you can find it online. And he talked about what they've done in his hospital group, which is in Boston, and they have, across a number of hospitals, they have 75,000 employees, so huge. And in addition to the hand washing and the temperature taking, he listed a number of things, but one of the things was culture. And he talked about a culture of openness where, if you see, for example, a surgeon who is walking down a corridor who is using the mask inappropriately in terms of current infection control of the kind of COVID needs, you need a culture where whoever you are, you can just say politely, you know, I think you should have taken your mask off, I'm really sorry, whatever it is. And I think that by extension, we need to think about the culture, and that can be, although it's difficult, it can be at times be bottoms up. So that if you see a more senior doctor who has behaved in an uncompassionate way to another trainee, one of the really difficult things is speaking truth to power. And obviously politely saying, and after saying, I just wonder if we could have a word, and saying, you know, Jane, John, whatever, looked a bit upset about how, you know, how that, and it is, you know, we all know it's, of course we're already stressed, but it's not comfortable to be told off in front of the team or whatever it is, actually, and you have to model that rather than the temptation is just to get on your WhatsApp group and saying Dr. X was just been I shan't use bad language, but has just been in their normal way. To actually model a way of saying, you know, I understand, I know we're all a bit tired and stressed, but it seems really quite upset by what you said.
Absolutely, we really need to think about our feedback skills in that way. Just
including upward management, really hard.
Absolutely. Okay, so there are no more questions that I can see. I think maybe best to leave it there. And thank you so much, both of you, for just coming and giving us your thoughts, your insights. You've had so much experience in this area and we really appreciate it. Just for everybody, thank you. We've got the feedback link in the chat box, so we really appreciate your thoughts. It's also on the LSP website. So unless anybody has anything else to say, we'll just close the meeting there. Thank you so much.
Great. Thanks.
Goodbye.
Bye.
Bye.